Dr. Brian Coe. He's a foot and ankle orthopedic surgeon at Dexter Orthopedics. He's going to talk to us about foot and ankle.
My name is Dr. Brian Coe. I'm an orthopedic surgeon with fellowship training in foot and ankle. So that is 99% of my practice is just foot and ankle. So I just want to talk today about the most common injuries with an emphasis on work injuries that I typically see in my practice. And if you guys have any questions, I think it's a lot more effective if you guys just ask them as they come, because usually they're related to whatever I'm speaking on. So feel free to raise your hand, interrupt me. We'll try to get those questions answered as we go, but we'll still have some time at the end if you guys have any questions. Okay? So let's just start off with a little bit of anatomy, specifically on the ankle. The ankle is a ball and socket joint made up of 3 bones. On the top, what makes up the socket is the tibia and the fibula that you can see here. And then on the bottom, what makes up the ball of the ball and socket is a bone called the talus that you can see here. Ankle injuries are very, very common injuries. The most common causes, especially with an emphasis on what happens at work, are falls, twisting type injuries, uneven work surfaces, which can cause you to slip or fall or step the wrong way. And these type of injuries most commonly cause ankle sprains. So that is by far the most common work injury, as well as injury in the foot and ankle outside of work. So these are typically what's called an inversion type injury, where, as you can see here, the ankle rolls in. These make up 85% of all ankle injuries, and about 30,000 of these occur every day. So very, very common injury, happens a lot at work. So what this is what we call a partial ligament tear. So these ligaments that you can see here on the outside of the ankle joint help stabilize and keep that ball and socket in a good position. And when you roll the ankle, it pulls and stretches these ligaments, and you get a partial tear. So when you first see these patients in the office, typically you'll notice they have a lot of swelling, a lot of bruising, and then they have pain with walking depending on how bad the sprain is. You can see here this patient's got a lot of swelling on the outside of the ankle that extends down to the foot, and you can see those purple color changes down by the heel. That's that bruising that we typically see. So the first part of the evaluation is we'll get some x-rays, and that's because we don't want to miss a broken bone. That's going to be a lot different treatment from an ankle sprain. So a normal ankle x-ray, you can see it here on the left, and on the right you can see there's a broken bone of the fibula, and you can see it's shifted a little bit. So we want to make sure we're not missing these kind of fractured, broken bone injuries. So the next step is, should we get an MRI? And the answer is almost always no. The reason for that is because even though there may be injuries that we're not seeing, and an MRI would be the only thing that would catch it, so these injuries would be like cartilage lesions or tendon tears. The most important thing is, even if they have those injuries, it doesn't change our treatment. We're going to treat them exactly the same as if they only had an ankle sprain. So there's no need to get an MRI because it doesn't change our treatment. So what is the treatment? You guys have all probably heard of the term RICE. So very common ankle sprain treatment that stands for rest, ice, compression, and elevation. It's a good mnemonic to remember, and it's only part of the treatment, but it's definitely a good start. So let's go through what that means. So the first part is rest. What that really means is we want to mobilize and we want to protect the ankle so that the ligaments can heal, and they can heal in the appropriate position. So it holds the alignment and allows healing of those ligaments that were torn. The most important thing about ankle sprains is they're all different. You could have a mild sprain that's basically you're walking normally within an hour or 2. And you can have a sprain that's so bad that you're in a boot for up to 6 weeks and may not be able to walk for the first week or 2. The difficult part is it just depends on how bad the injury was and how much of the ligaments were damaged. So what we do in the clinic is we just see how they feel. If they have a lot of back pain, we'll start them off in what's called a walking boot, which you see pictured here, gives the most amount of support, but is the most bulky and the heaviest. And then once patients are walking this pretty comfortably, then we'll typically transition patients into a lace-up ankle brace so they have a little bit less support and a little bit more mobile. They can drive in the brace where they can't drive in the boot. And then eventually we transition them out of the brace. Now for patients that have mild ankle sprains where they're walking into clinic and they have some pain but they're still able to put weight on it, typically we'll start them off in the ankle brace right away and forego the boot. And so that just depends on how bad their pain is and how bad of a sprain they have. So the next part of our RICE treatment is ice. So ice is important because it helps with swelling control. Ice helps decrease the swelling, calm down the inflammation healing process. So I typically tell patients, try to ice about 20 minutes on, 20 minutes off, especially at the end of the day when the swelling is typically the worst. Swelling typically gets worse throughout the day because gravity tends to pull fluid down to the bottom of your body, which happens to be your ankle and your foot. So the next part of our RICE treatment is compression, also helping for swelling control. Basically, you're wrapping the ankle with some kind of elasticity that pushes against the skin. So it basically prevents the swelling from accumulating, tries to push the swelling away. So compression wraps can be helpful. One device that really has changed the way we manage icing and swelling is a cold compression device. And so what this device does, this one particularly is called a Game Ready, but there's multiple products that do the same thing. They provide continuous icing without having to replace the ice, and they provide intermittent compression. So this basically pumps up in this little sleeve around the foot that helps force the swelling out. And so it can be very helpful in bringing down the swelling quickly in these patients. So the next part of our RICE treatment is elevation. So also part of swelling control, and probably the most effective out of all of these. Basically, we're elevating the leg, typically to the level of the heart, because swelling goes where gravity goes. So if the foot is sitting on the bottom of the ground, and I'm sitting down with my foot on the ground, gravity is just going to pull all of that swelling and it's going to accumulate there. When I prop the leg up to the level of the heart, so when I'm sitting down, I put my leg up on a chair, or when I'm sleeping at night, I put my leg on a couple of pillows like you see here. That allows gravity to naturally pull the swelling away to the lowest part of the body, which is now not in the foot. So the most important step after an ankle sprain is actually, once we get everything calmed down, once we get the swelling under control and the patients are feeling better, it's actual physical therapy. And the reason is that after these ankle sprains, there's always going to be some level of weakness and stiffness that in order to get these patients back without having any issues in the future, we have to build up that strength and flexibility. So physical therapy focuses on strength, stretching, a lot of that tightness out, and most importantly, the balance. So the balance basically, most importantly, is getting your muscles to work in conjunction, having good body awareness of where your foot and your ankle is in space. And this not only helps get them back to their level of activity, but helps decrease the risk of future injuries. So a lot of times, you or a family member or friend may have noticed patients get an ankle sprain, they kind of blow it off, and then they have pain that's not as bad, but a little bit of pain that never quite goes away. Or they are doing okay, but they, for some reason, keep spraining their ankle over and over again. A lot of this is because, number one, they didn't let the ligaments fully heal, but most importantly, they never had a chance to build up that strength, flexibility, and balance. And so if we do that, that'll decrease the chance of re-injury. So if you try this treatment and these patients are still having pain, that's when we start thinking, are there associated injuries that we need to do something about that may be the cause of this continued pain? So those injuries are going to be things like cartilage damage in the ankle joint or tendon tears, like the peroneal tendon. So this would be the appropriate time to get an MRI. You see a standard ankle sprain, you treat them appropriately, but they're still having pain. Then you're thinking, are there other things that need to be treated and addressed? So here's an example of an MRI. You see the ankle joint here on the lateral part. There's a cartilage lesion where you see there's kind of a pothole there where the cartilage has been disrupted. So what is the treatment for these cartilage lesions? If they're symptomatic, we typically try a steroid injection, which can calm down the inflammation and get rid of their pain. If you try these things and they continue to have pain that's not getting any better, that's when you think about surgery. So what does surgery entail? Basically, we use special instruments to remove all that cartilage that has been damaged and flipped up, so it's kind of just flapping around, it's not stable, it's not doing its job anymore. We take all that out, and then we do what's called a microfracture, which you may hear a lot of, especially NBA athletes get in their knee. Basically, we drill these small holes through the bone to try to release the body's own stem cells and bone marrow to try to fill in that pothole with new healthy cartilage. So here's just an example of what that looks like. This is a picture inside the ankle joint, and what you see right in the middle there, it looks like there's a little bit of a pothole, but it doesn't look too bad. When I stick a little instrument and start trying to move it around, you see this whole thing is unstable. It flips right up. It's not attached to the bone, and it's not stable like we want it to be. So we want to take all that out because it's not doing its job anymore. It's going to be unstable and floating around, causing pain. So here's what it looks like after we've taken out all that unstable cartilage. And then we do our microfracture, which is we take this little drill and we punch these small holes into the bone. And you can see it's already starting to release a little bit of blood. That bone marrow and those stem cells are going to hopefully help regenerate and fill in that gap with new tendon over time. So that's treatment for cartilage damage. What about if they have a tendon tear? The most common tear, especially after an ankle sprain or with an ankle sprain type injury, is what's called a peroneal tendon tear. The peroneal tendon comes out the outside of the ankle, which you can see here, wraps all the way around the ankle and attaches to the outside of the foot. Very important muscle for especially balance and uneven surfaces. And typically when you get a tear there, it's a tear long ways. So the tendon is still intact, but there's a tear within the tendon, kind of like cream cheese. And that can be very painful. So we always start with physical therapy, but in these patients with these ankle sprain type injuries, typically you've already done therapy, they're not getting better. You can consider a steroid injection. And the most important thing is if you can get rid of the pain with a steroid injection, you don't have to fix the tendon. That tendon tear is never going to heal without surgery. But if they're pain-free, the way the tendon tears, the whole tendon is still intact. So you don't necessarily need to do a surgery. So if they have continued pain though, that's when you consider a surgery to repair that tendon. So here's a little picture of what the tendon looks like, and you can see that tear long ways. That's how it typically looks. And basically, to repair it, we do this kind of baseball stitch. We clean out the tear and we just stitch it back up. Pretty straightforward, and it should heal over time. So this is what that looks like in a patient. You can see that tendon, we just have this baseball stitch wrapping it up, and that holds the tendon in place so that little tear can heal over time. So let's move on and talk about other work injuries. The most common injury after an ankle sprain is going to be some kind of broken bone. We call these fractures. And you can fracture pretty much any bone in the ankle all the way down to the foot. So here's an example of an ankle fracture. And so you can see the normal ankle on the left, and on the right you have a severe injury where basically the ankle is broken into multiple pieces, it's shortened. And so this is something that typically does require surgery. So, what are the most common causes of these injuries at work? For these higher energy injuries, one of the most common causes is a fall from height. So the most important thing when you think about fall from height is, if you search on the internet, this is how people think you fall. So at work, this is actually not the most common way people fall. Usually they land feet first. So it's something where they slipped off a ladder or a height, they're able to catch themselves and at least land on their feet, but maybe they didn't land the right way, or they fell from a really high distance, so there was enough energy to still cause a broken bone. So with these feet first falls, you get what's called axial compression, which means there's a lot of force pushing right through the foot into your heel, and it gets transmitted to the rest of your body. And what this can do is cause a very common set of injuries where the weaker parts of the bones basically get crushed. So common broken bones from these type of high energy falls where you land on your feet, you break the heel bone, you break the ankle, you have injuries to the knee bones as well as the lower back. So we're just going to focus on the foot and ankle injuries today. So we'll start from the lowest part of the body, the part that typically contacts the ground first, which is your heel. One of the biggest causes of heel broken bones is fall from height. So here's the heel bone right here, it's called the calcaneus. And this is what it looks like. You can see the heels in the back right here, that's what the normal bone looks like. And the reason this happens is the talus, which is the bone right above the heel bone called the calcaneus, is the hardest bone in the entire body. We call it the nutcracker. So basically when you fall, this talus bone that's sitting right on top of the calcaneus gets driven right down into the calcaneus and basically crushes it. So the talus acts like a nutcracker, crushes the heel bone below it. And so here's a normal bone. Here's what it looks like after an injury. So what you see here is, here's the normal contour of the bone. Here's that part of the bone that just gets smushed down. And then you can see, you see how it's smushed down lower? That part of the joint just gets crushed down. So these type of injuries typically need surgery if there's a lot of what we call joint collapse or bad alignment. So basically, if you have an injury like this where the heel is crushed down, or you have a patient where because of the way the heel got crushed, it got tilted to the side, those are patients that you would typically consider surgery for. Now, there's going to be a lot of injuries that are maybe lower energy or not as bad, where you can see here, there's a tiny little crack, which if I don't point it out, you probably can't even see. The overall alignment is good, the joint is in a good position. This definitely does not need surgery. It's going to heal just fine if you put it in a cast for 6 weeks. So for most of these patients, a lot of times we'll delay surgery. We'll wait about a week or two to actually do the surgery because usually these surgeries are high energy. They're falling from height. Not only are the bones broken, there's going to be a lot of damage to the soft tissue, the surrounding muscles, the surrounding skin. You can see on this patient there's a lot of bruising. You can even develop huge blisters that we call fracture blisters. And that's because there's so much damage to the soft tissue that it forms a blister, kind of like if you burn yourself. So we want to wait for a lot of that tissue to heal before we think about doing the final surgery, or else we're going to have a lot of wound problems that skin can actually die, and then we're staring at bones and our metal, and that's not good. So here's just an example of what the surgery looks like. We make our incision, and we use this little pin that we put in temporarily that we use to try to bring that heel back into the alignment we want. So you can see that when we try to bring it down, because it usually gets crushed, so we build that height back up. And then after we do that, usually we put a plate of screws on to hold the alignment that we've restored so the bones can heal in the right position. And so we stick our plate on, we put our screws in to capture each of these small fragments that are broken, and then that's going to make sure that the bones heal in the right position. So that's what you see here. We finished putting in the screws. So here's an example of a case where you saw before that calcaneus was crushed, and then you can see that that portion that got pushed down, we brought it back up, we've held it there with a plate and some screws, and it's been able to heal in that good position. So let's move on further down in the body. Let's go to the middle of the foot. So the midfoot is this area right in the middle of the foot that is also commonly injured. The most common cause is fall from height, or it could be you just landed the wrong way. And the way patients typically land is basically this common injury called a Lisfranc injury. And what happens is you put a lot of pressure when the foot's in a pointed position like this. And this is a very common injury. You can imagine there's a police officer chasing somebody, they jump over a fence and they go to land. They're landing toes first, but they don't land quite right because maybe the ground's uneven. Puts a lot of pressure right through the middle of the foot, and then a lot of times those bones can break or get popped out, and they can actually dislocate. So a Lisfranc injury is an injury involving the middle of the foot, and basically the alignment is disrupted. So that could be by breaking the bones or tearing the ligaments in the middle of the foot. So just to give you an idea of the foot anatomy, if you take the foot and we take some slices out of the foot as if we were slicing deli meat to see what the alignment looks like, here's an MRI. That's what the foot, the middle of the foot looks like when we take those slices. And you can see there's this what we call Roman arch shape. So basically the bones are stacked on top of each other so that when you push down, they interlock and provide stability. During this Lisfranc injury where the ligaments are torn, this perfect alignment gets disrupted. And then the bones aren't interlinked, so they're not providing stability anymore. So these are injuries that are very important to fix, or else the foot's not going to be able to function the way we want it to. So here's an example of a normal foot, and here's an example of what we call Lisfranc injury. You can see normally the bones are lined up in a straight line, and over here they're completely disrupted. Okay, they're almost dislocated because part of the foot has been shifted up, that Roman arch has been disrupted. So here's a normal foot on the left. Here's what we call a Lisfranc injury, where basically there's a normal line where the bones are lined up. Here you can see it's completely disrupted, and the big toe bone is shifted all the way to the left. The rest of the bones have shifted all the way to the right, so it's completely dislocated. So on exam, these patients have a lot of swelling, a lot of pain, and classically they'll have bruising on the top of the foot. This is something that you have to pay attention to. This bruising on the top of the foot, you got to think, is there something bigger going on? The reason is these are often missed injuries. These will be blown off as a foot bruise or a foot sprain. And the problem is these injuries need surgery. Usually if you miss these injuries, you catch them 6 months, 1 year later, they've already developed arthritis, and now it's a different surgery that they need. So here's our previous patient. You can see the disruption there. And then we put the bones in the right position, hold it with plate screws, and now it's nice and lined up. Here's where it was before, and now we have everything lined up and held together with plate screws. And these patients typically do very well if you catch these injuries, get them into a good alignment and heal. So, moving on up in the foot. Last and most common is ankle fractures. So, these can be really bad injuries. You can have really bad alignments. So here's an example that I showed earlier of a normal bone on the left and a bone that's broken, shattered on the right. So these injuries usually need surgery. There's bad alignment, and we want to fix that because if they heal in that position, they're going to have a high risk of arthritis. So a lot of these can be very, very high energy injuries. Similar to the heel injuries, they can have a lot of what we call fracture blisters, which we see here, a lot of swelling. For these bad injuries, like the one I just showed you, especially if they fall from height, you don't want to do the main surgery right away. We'll typically split the surgery into 2 stages. So the first stage, basically we get temporary alignments. We don't make any incisions because those would be potential areas where the skin and wounds can break down. We want to get temporary alignment so the soft tissues can heal, and we can go back after about 2 weeks and do the final surgery and get everything perfectly lined up. So usually we want to wait until we get what's called a wrinkle test. Basically you bend the foot up and I can see wrinkles in the skin, which tells me there's no swelling anymore. Now we can do the surgery. So for this first part of this surgery, we typically do what's called external fixation for these bad injuries. That means we temporarily hold the alignment with these pins and this frame that sticks out of the skin. This is safe to do because we're not making incisions. We're just making some tiny little poke holes to temporarily hold a good alignment. So you can see here's the initial injury, here's after we put that external fixation on. Doesn't look perfect, but you can see we've at least pulled the bones out to around the neighborhood of where they're supposed to be. And then we can wait. So this allows the soft tissue swelling to heal. We wait 2 weeks, we come back and we do the final surgery where we actually put the bones in the right position with plate screws. So here's our original injury. Now we have it nice and lined up with plate screws. All those little fragments are where they're supposed to be. And here's the patient 3 months after surgery. We get them walking, bone was good, they're doing really well. So this is the part after everything is healed, we start physical therapy, which is going to be pretty key to pretty much all foot and ankle injuries. The key, like we mentioned a little bit before, is we want to restore the motion, the strength, and the balance. So just to give you an idea of this last patient, they were in a frame where the ankle is not moving or bending for 2 weeks. Then they had the surgery, and usually they're in a cast or a boot for 6 to 8 additional weeks. So this is almost 10 weeks before they really start moving the ankle. They're going to have a lot of stiffness. If we want to get all that function back, therapy is going to be key. So looking beyond physical therapy, we also want to think, what is their job? Because not every job is the same. Therapy for someone who's going to go back to a desk job can be a lot different from a police officer or a firefighter, someone who's up on their feet all the time. So you want to think about their work requirements. Some patients are going to have very, very heavy work requirements, very long shifts. They're going to need different therapy than other patients. So that's where work hardening really comes in. Work hardening is basically, instead of going to work, they go to therapy and they practice doing the things that they would do at work. They practice moving, whatever their job entails, they design a program where they're doing those simulated activities at work. And that's really important, especially for the high function jobs. So like your firefighters, like your police officers, if they just do therapy where they do some band work, some balance stuff, some stretching, that is in no way going to prepare them to potentially have to carry someone out of a burning building and down a bunch of ladders. So you want to try to simulate that as best as you can to get them ready to go to work. And the other thing to think about is how long their shift is. Therapy is going to be an hour a day, 3 times a week. for most jobs that are active, that's really not going to simulate being up on your feet for 8 hours or 12 hours or whatever their shifts are. So this allows longer time periods. They may go to work on you for 4 hours, 6 hours, 8 hours. That'll get them closer to what they actually need to do at work so that they can go back to work and be able to handle it. The last thing is what we call functional capacity evaluation. This is usually, I think, of like the final exam. Basically, it's a test that basically shows what they can and can't do. A couple of things about that is, first off, a lot of these devastating injuries, patients do not regain full function. So in these patients, you want to consider a functional capacity evaluation. This is basically a defined test. They put them through specific movements, specific tests that are the same for everyone. Lifting, pushing, pulling, standing, walking, flexibility and reaching, grasping, holding, bending, and balance. And it basically shows what they can do and what they can't do. Now the important thing is the functional capacity can help the patient. It can protect them with permanent disabilities where they say, this test shows that you can't do this, so we can't have work demanding you to do these things. It protects the patient. But you also have to remember it can hurt the patient. These are going to be permanent disabilities. So if the patient has this permanent disability and they go to get a new job that requires them to do this, that may hurt them from finding a new job. So we just want to make sure the patient understands that they're okay with that. The other thing is the functional capacity evaluation may not truly evaluate their job. And so let's go back to the firefighter and the police officer. If you put this patient through a functional capacity evaluation, they may say everything is fine. Yeah, you can lift 50-pound boxes. Yeah, you can walk for an hour. Yeah, you can twist, bend, lower your back. But does that truly capture what you may have to do at work? Probably not, depending on what you're doing. So that's something to also keep in mind. If you get a functional capacity evaluation and it says they can go back to work, but the patient's telling you, hey, look, this has nothing to do with me. I'm actually doing my job. I can't handle this. You have to remember that they may not be ready. So our end goal is always to get the patient back to work, get them back to as normal of a life as possible. And if you guys have any questions, please reach out. And I have my email here if you guys want to reach out with any questions or concerns later, feel free to email me. So go ahead.
Can you talk a little bit about the pathophysiology of these articular heart disruption? And then secondly, what are the indications for microfracture surgery?
Okay, so the question is, number one, what are the causes of the cartilage injury? And number two, what are the indications to do surgery? Is that right? Microfracture surgery specifically. Okay, so the first one, what are the common causes? The most common cause is an acute injury. So basically, these inversion or twisting type injuries are the most common. They basically cause a lot of shearing force on that cartilage, which can disrupt it. Other causes is mostly we don't understand. We know there are associated conditions that put them at more risk, but we don't know how or why it happens. Sometimes it's degenerative, just wear and tear over time, and that cartilage becomes weak and gets cracked, and that crack expands over time. So the second question is specifically when to do a microfracture surgery. Typically, when you know there's disruption of the cartilage, and when you clean it up, if you can see bone, if it's large enough to see a bone, typically I'll tell those patients I would recommend a microfracture, because we want to try to get that empty bare space to fill in with cartilage. Now, there's a lot of literature that shows that patients can do well even without a microfracture. If you just take out the unhealthy cartilage, a lot of patients will do fine. Usually that's a discussion that I have with the patients where I tell them, typically I'll recommend a microfracture. It recovers a little bit longer, but it gives you the best chance that that's going to fill in with cartilage. And literature shows that most of those patients typically do the best. Now, there is literature showing that patients still do well without that. So if patients say, I don't want to be off my feet for 6 weeks, I want to be back in 2 weeks, I'll tell them we can just clean out that unhealthy cartilage and not drill those holes, shorter recovery time. Other questions?
Utilization review routinely denies the game ready machine. How do you respond to that?
So utilization review denies the game ready machine. I don't have a great answer for that. I'll tell you that my typical response to that is there's literature that shows improved outcomes in the knee, especially after ACL surgeries, improved outcomes in the shoulder after rotator cuff repairs. There's no literature in the foot and ankle itself. So we use it, we correlate this is a similar type of injury. It's been shown to work in the knee and the shoulder. It helps in the ankle.
But there is literature supporting the knee and the shoulder.
Correct. Other questions?
What's the difference between a regular ankle sprain and a high ankle sprain, and what's the main difference between them?
So what is the difference between a normal ankle sprain and a high ankle sprain, and is there a difference in treatment? So a high ankle sprain is you're tearing different ligaments. So a normal ankle sprain is you're tearing the ligaments on the outside of the ankle. A high ankle sprain, let me see if I can go back and show you a picture. Okay, so a normal ankle sprain is you're tearing the ligaments on the outside, typically right here, or the inside. A high ankle sprain means you're tearing the ligaments up higher that connect the tibia and the fibula. So with a high ankle sprain, if those ligaments are completely disrupted, the ankle, the ball socket joint falls out of alignment. That's something that needs surgery. Outside of that, the treatment options aren't, the treatment isn't really different, other than the high ankle sprain is usually a higher energy injury. It typically takes longer to heal. So they may spend a little bit more time in the boot, but otherwise the treatment is the same. You protect them with a boot and then a brace until the ligaments have healed and their pain is gone, and you start some physical therapy. Yeah.
What is the significance of the Weber classification, where you see like a Weber B fracture?
So what is the significance of the Weber classification? And this classification is specifically in regards to fibular fractures, so the green bone right there on the outside. So the Weber classification helps give us an idea of whether we need to do surgery or not. So a Weber A fracture is fractures that are basically from here on down. Those almost never need surgery because they're stable injuries that don't disrupt the ankle. The Weber B, which is up in this area, could need surgery. Usually we'll do a test in the clinic called a stress test to see is the ankle shifting into a bad position. And if it is, then it needs surgery. If it isn't, it does not. A Weber C fracture is high up. That is typically just associated with the disruption of those high ankle sprain ligaments, and that almost always needs surgery. So that's just a description of where the bone is broken, but gives us an idea of is this something that needs surgery or not.
In the microfracture, how is it that these little holes will help tissue regeneration?
So in a microfracture, how do these little holes that we drill help the tissue to regenerate? So basically, normal bone has, basically I would think there's bone, and then on top of the bone, there's an area of the bone called the cortex, which is the thickest, strongest part of the bone. So if the cortex is intact, it's going to stay like that. It's never going to heal because the bone doesn't think there's anything wrong, even though the cartilage sitting right above that is normal. So I would think of this kind of like aerating your lawn. Basically, it allows the channeling of nutrients from deep underground up into the surface to fill in that hole. So if you have a dead patch of grass, and you're trying to get grass to grow in a patch of soil, you want to fertilize the soil, you want to break up the soil so the seeds can take. Same idea here, you want to break through the cortex so that the bone marrow and the healing factors can basically escape into the area that you want to heal. Otherwise, you're never going to get to that area. They're never going to start that healing response.
Doctor, in a typical high impact ladder fall where there's a fracture of the fibula that you put in, those internal fixations, what's life expectancy on the plates and screws? Do those come out after 10, 15 years, or do they stay for life?
Okay, so after an ankle fracture, if I put in hardware plate screws, what is the life expectancy of those plate screws? So the answer to that is that those can stand for the rest of their life unless they cause any problems. So typically about 10% of patients have issues with the hardware. Issues being they can feel it, it rubs against their shoes or their clothes, and we have to go back in and take the hardware out. 90% of patients don't have any problems and it can stay in forever without causing any issues. There is one specific surgery that some surgeons do to hold the bone, the two bones, the tibia and the fibula. So say you had a high ankle sprain that disrupts these ligaments. Some patients will put a screw in here to allow those bones to heal in the right position. there's been new technology that's come out in the past decade or so, where instead of putting that screw that we do have to go back and take out later after about 3 months to 6 months, now we put this little thing called a tightrope, which allows for some motion, and then we don't have to take that out. So that is an area where advanced technology has removed the need to have to do an additional surgery to take that out. Other questions? Yeah.
What is an ankle fusion and when is it needed?
So an ankle fusion is basically when we dig out all the cartilage in the ankle joint right here. So we dig all this out, and we put plate screws in to try to get these two bones to basically grow and fuse into one bone. So we typically do this procedure for patients who have arthritis, where wear and tear or trauma or injuries have caused the cartilage in the ankle to be worn away. So then the bone of the ankle joint is rubbing right against the bone, which is really painful. So the way we get rid of that pain is we get rid of the joint. You fuse it into one bone, so you don't have arthritic bone rubbing against arthritic bone anymore. The downside of that is patients lose the ankle motion. Other questions? Yeah.
Did you say this fracture is bruising on the bottom of the foot or the top?
Bruising. Okay, so a Lisfranc fracture, the question was, is there bruising on the top or the bottom of the foot? In a Lisfranc injury or fracture, typically you'll see bruising on the bottom of the foot, in the arch area. And that should be a big tip-off to, is there a Lisfranc injury? Because there are really only two things that classically cause bruising on the bottom of the foot. One of them is a Lisfranc injury. The second is a plantar fascia rupture. Other questions? All right, great. Thanks for having me.